Okay, so I'm recording, guys. So thank you guys for coming to the fourth live boot camp session. So in today's live session, I'll be kind of finishing up the last couple topics on how to master the wards, which includes talking about the X-rays, EKGs. I'll be going over antibiotics, fluids, and I'm also going to give you guys a primer of the ICU. So I think it's important to really kind of have those topics, have a basic understanding of them before starting residency. And then I'll be expanding on them through other videos that I'll talk to you guys at the end of this live session, how to get access to those videos. So kind of to begin, I'm going to go over kind of the curriculum that I sent out to you guys, reflecting on kind of the things that we talked about last couple sessions. We talked about wards, we talked about presentations, we talked about forming differentials. But really the most important thing is, acquiring knowledge. You really can't form a differential if you don't really have the knowledge to be able to understand how to take a chief concern that a patient has and forming it into different systems that might be affected, that chief concern might be affected by. So in today's talk, again, I mentioned the things that we're going to talk about, but I also want to mention a couple of things more relating to efficiency, how to be more efficient, how to co-consults, and how to multitask. So that's something that I'll be kind of finishing up the live course with, kind of give you guys examples on how do I do take, multitask when I was a senior, and how to co-consults. I am a pulmonary critical care fellow, so I mostly do consults now. I am the primary care physician in the ICU. So I kind of have experience, dealing with consults on both ends. When I get called about a patient who's crumping and needs to be admitted to the ICU, or when I get called about a patient with a pulmonary problem when I'm in pulmonary consult. So I'll give you guys my own kind of advice on how to call consults when it comes to that. So let's just kind of get started in terms of interpreting X-ray. So that's kind of something that's really important for you guys to kind of have a basic understanding of. And you guys probably already know how to interpret an X-ray. So, but in any case, I'm going to walk you guys how do I do it. So there's a couple of ways of interpreting an X-ray. You have to have a system. Doesn't matter which system you have. I think as long as you're systematic and you're able to kind of make it so it becomes natural for you. When an attending asks you how to interpret this X-ray, you kind of already know your system. My system that I like to use is the ABCs, really, ABCs, and that really comes down to identifying the airway. Airway. And then B would be bone. C would be cardiac, right? And then you have the other ABCD, right? So it's like the alphabet, diaphragm. So you want to make sure you look at the diaphragm. You're able to comment if there's any fluid around there. You also have E and F, which is essentially kind of everything else. That's more of the actual lung itself. Is there opacities? Is there vascular congestion? All these things. And then you have G, which is gastric bubble. Kind of looking at that. We'll look at that not in detail, but just kind of briefly. And then you have the H, which is the hilum, and then mediastinum, essentially. So looking at the actual cardiac borders and commenting on the heart itself, which is it's essentially kind of the same idea with cardiac, but just a reminder of making sure that you're not missing anything else. And then you also have I, which is kind of invasive stuff like lines, especially if you're in the ICU, looking at the central lines to make sure they're in place, looking at the endotracheal tube, which also has to do with the airway. But I'm going to screen share something for you guys so that you guys can look at the example that I do. So give me 1 second to screen share my page. My screen, I'm going to screen share it. Okay. Okay, so you guys see, do you guys see the X-ray? Trying to figure out, I wish I could see what I'm sharing. Are you able to see the X-ray, guys? Okay. So, you have the clavicle, you have the trachea here. And so you're looking at the airway, you're going to obviously say, the airway might be, make sure it's patent. So you actually make sure that it's patent. You also want to make sure that if it's depending on the patient's rotation, You also want to make sure that the clavicle is the spinous process is midline between the clavicles. That tells you that the patient's not rotated. And then this is obviously clavicles. B is bones, making sure there's no damage or fractures in the bones. C is cardiac, looking at the cardiac silhouette. Usually if it's usually kind of looking at, if it's larger, you kind of grab, the way that I remember is from, can you guys follow the cursor that I have, or is that something you guys can't see? I want to make sure that before I say that. I'm moving a cursor on the screen. Yeah, you can see it. Okay. All right, great. So this is the heart, right? So this is from here to here. I kind of look at it, if it's from here to here, if it's pretty much the same size from here all across, that's cardiomegaly. That's kind of a good way of estimating if it's cardiomegaly. So this patient has a normal heart from here to here, and you kind of take that size and measure it, probably here. It's not extremely large. And then you also have D for diaphragm, making sure there's no costophrenic angles. So this is the diaphragm here, right? If there's pleural effusion, you'll see pleural effusion be filled here, and you'll have blunting of the costophrenic angles. So that's D. And then E is pretty much everything in the lung itself. Looking at it specifically, these kind of, this is all vasculature, pulmonary vasculature. That's normal. You'll sometimes have, depending on the presentation, opacities. If there's like a pneumonia, if there's a large consolidation, you could see basically consolidation is the airways are filled with something, right? So it could be fluid, it could be blood, which is a type of fluid, or it could be just kind of in general other things. So that shows us something called opacities, or a consolidation is more it's more filled. Opacity is less filled, essentially. But that could be kind of spread out, and you'll see this patient doesn't have opacities. I don't want to show you too many things because I think that is that's more in-depth discussion. I just wanted to kind of give you guys a better glimpse of how to be systematic with reading X-rays. But I think during your training, you'll get better examples in terms of actual pathology when it comes to opacities, consolidation, etc. And then you also have sometimes reticular opacities, or reticular markings here. But if this patient is normal, vasculature is here. Sometimes this vasculature itself will be thicker. That's called increased vascular congestion, especially for edema. And this is the heart border itself. You're looking at the aortic knob here. So there's the right side. When you have pneumonia, right lower lobe pneumonia, usually it blunts, it hides the right atrium border. Or if you have a retrocardiac opacity, it'll blunt the left ventricle border. So you won't see this line. Instead, you'll see like a filled space, essentially. So that's important for you to understand is it hiding structures behind the heart? So, you have something that's filled, and maybe the X-ray is not being able to pick up the heart borders because something is filling the lung. And that shows as an opacity, basically. So that's kind of really most of the EKG that you would be expected to know and interpret. So let's just go back to the whiteboard. So sorry, I don't know. Let me go back. Give me 1 second, guys. Are you guys able to go? Do you guys see the whiteboard again, or am I still sharing the other screen? X-ray. Okay. What about now? Google Images now. Okay. Can you guys see the whiteboard now? Okay, go. Okay, great. I'm good. So that's essentially kind of the. Sorry, guys. Give me 1 second. This is really confusing. Like I have multiple, but let me give me 1 second. I'm gonna close. Which whiteboard are you guys seeing? Am I circling? There's like a green thing. I'm sorry, I'm just making circles. Do you guys see that? Because there's 2 whiteboards, and I don't want to close the one that green scribes. Okay, let me close the other one then. Okay, that makes more sense. Okay, so let's so that's kind of the way that I kind of start with reading X-rays. Okay, then so then let's talk about interpreting EKGs. How many of you guys feel comfortable interpreting basic EKG? Okay, so then let's talk about EKGs for a second. So I'm going to share another screen with you guys. And this one I think is hopefully I'm able to do it better. Apologize why I wasn't able to do the other one. Okay, so this one is interpreting EKGs, and this is kind of, you guys could take a picture of this. This is something that I used when I was a resident, early intern and medical student. So really the most important thing is, again, the whole key with, if you notice, with everything is being systematic. When it comes to chest X-rays, being systematic with your approach. When it comes to EKGs, similarly, being systematic with your approach is going to be helpful. So my recommendation is to kind of follow something. The way that I like to be kind of systematic is in making sure I interpret the heart rate, and then intervals. These are the intervals that are important. But in terms of heart rate itself, you want to comment if it's in rhythm, what rhythm it is, right? And not only is it tachycardia, but is it sinus tachycardia, meaning there's an impulse from the atrium to the ventricle, or is it ventricular tachycardia, meaning there's no impulse from the ventricle or from the atrium? The pacemaker from the ventricle itself takes over, so that's why you have enlarged QRS. So you have to make sure that when someone has ventricular tachycardia, the QRS will be large, right? Will be large essentially. And then you also want to comment if the P waves are absent/present. Are they normal, abnormal, meaning that they have the same morphology? Are they one QRS, for instance, is small, the other one is large, etc. So want to comment on that. QRS complex, wide or narrow, and P to QRS ratio, meaning for every P is there a QRS, or is there something a ratio that's not consistent? Is the rhythm itself regular or irregular? Is a pattern that you see irregular or not? And that kind of gives you an idea what rhythm it could be too. So that's something that you want to also kind of keep in mind when you're kind of systematic. Axis deviation, you have to kind of remind yourself about the axis, the way that the degrees are. But in general, kind of a quick look method is kind of knowing that normal axis. Normally, if you have a positive lead, meaning that it's pointing up, in lead 1, AVF, lead 2, and AVL, that's typically going to be a normal axis. Left axis deviation is if you have basically kind of instead of AVF being positive, it's going to be deflected down. That's going to be AVF is going to be deflected down, and lead 2 is going to be deflected down. That's going to give you a left axis deviation. You could kind of see it based on the degrees of kind of the axis here. Right axis deviation is when AVF is deflected up, but you have a negative deflection of lead 1. Let me see if I could open the questions. If you guys have any questions about that. It's not, honestly, EKG interpretation during residency, it's really not that complex. Typically, I'll give you guys, I know that's a lot of info, but essentially this is like the quick, dirty way of knowing it. Basically, you're going to be called to evaluate a patient. who has tachycardia. Your first impression is, okay, what's the hemodynamics of this patient? Are their blood pressure normal or abnormal? Meaning, are they hypotensive or not? That's typically what we want to think about. And because the management will be different, right? And you can memorize all these things, all these rhythms, all these things. But the most important thing is you'll get practice with time. But you have to just be able to identify Afib. So number one, write it down, Afib. I'm not going to go over it with you because that's something that I'll go over in a different lecture. You want to identify Afib. You want to identify ventricular tachycardia, first of all. You also want to identify, make sure you have, if there's a bradycardia, is there a AV block? That's important. Is it first degree, second degree, third degree? Because if you have someone with second degree or above, you want to consider them for a pacemaker. Afib with RVR is basically when you have an irregular rhythm. RVR means rapid ventricular rate. Usually that's greater than 100. Not usually, always. It's defined as greater than 110 heart rate. That is important because the reason why you want to also make sure what their vitals are is because when someone has Afib with RVR, you want to control it. There's medications that drop their blood pressure. So if their blood pressure, if they are hypotensive, you would not want to use metoprolol. You would want to use something called amiodarone. And so that's kind of the clinical thinking that I want you to approach when you're learning, is not just memorizing all these, information. That's what you did as a med student. This is different now. As a resident, you're going to be applying what you're learning into the clinical setting. And that's really my goal for this thing is to really walk you through it. And I'll be honest with you guys, you'll be learning a lot as you go. And this boot camp definitely isn't here to make you more nervous about starting residency. There's going to be a lot of things that I'm going to talk about that are probably something that you'll learn with training with time. Definitely something I didn't know when I started. But this course is really for those who want to take an active role in their learning and want to really be ahead of the curve. Because I know that if I had an opportunity to know more coming in, I'll feel way more confident. I'll feel way more relaxed, and I'll actually enjoy residency. So that's really the goal. The goal is not to make you nervous and not make you think that you don't know anything. It's to walk you through things. And I will provide you with some cases with these videos, but there's a couple more videos that I'll talk about at the end of this course in which I'll be actually going more in depth with each topic, and I'll have more questions as well. Okay, so that's EKG discussion. Like I mentioned, all of this is kind of really introducing you to the topic that you'll have more practice in. It's not exhaustive by any means. I just wanted to kind of give you guys some idea of how to approach EKGs. So the next topic that I'll be focusing on is fluids. Do you guys see this? Which is the fluid compartments. You guys see the fluid compartment? Okay. So do you guys see my video too, or is it could you guys only see the page? Because I have my webcam on. You both? Okay, great. So fluid compartments, this is like a fluid discussion, is really important actually. So as an intern, there's gonna be a lot of things you need to interpret. You're gonna have a patient, you gotta it's like, think of it like a Lego, right? During residency, you're like building a Lego of medical knowledge. You're learning how to approach patients. Like the first step is taking their chief concern, understanding what does that mean, understanding what questions I should ask. Okay, now that they have do you understand their symptoms? What are each symptom associated with which diagnosis potentially? Okay, now that I know that those possible differentials, what do I need to rule it in or rule it out? Okay, I could ask more questions. Here's more questions that I could ask to rule it in. Maybe it's this based on timeline, based on symptoms, etc. Okay, now that I have that data, I have all these differentials. What else? What other data do I need now to rule in or rule out? Okay, then that comes with labs, that comes with imaging, X-ray, for instance. Oh, that comes with EKG, stuff like that. And now also the management. This is kind of more leaning towards management of what do you give, what fluids do you give when someone's coming in with certain things, right? So I think it's important just to understand the physiology of like just fluid compartments. Total body water, it's broken down into two-thirds of total body water. It's intracellular within the cells. Extracellular, you have 1/3 total body water, that's interstitial fluid. 3/4 of that is so it's a very small percentage. So 1/3 of the total body water is made up of interstitial fluid and plasma and extracellular fluid, essentially. And then so interstitial fluid is 3/4 of the extracellular fluid compartment, essentially. Sorry, I messed that up. You have interstitial fluid and you have plasma fluid. 3/4 of the total extracellular fluid is made up of interstitial fluid, and 1/4 is made up of plasma fluid, is made up of the extracellular fluid. So essentially what you're really targeting is you want to make sure really where you have plasma, you have all blood pressure, that's the interstitial fluid compartment. So I'll give you guys an idea of why that's important. So looking at different fluid ways that fluid is distributed after you give IV fluids, this is important. So really the target is intravascular, right? You want to hit the intravascular space. And that's when it comes, that's like kind of essentially this area, intravascular. This is like intravascular here. So you have intracellular fluid, which is intracellular fluid is here. This is like not that important. If you have D5W, a lot of it is going intracellular fluid. Not normal saline LR, none of 0 cc's. So some majority is going into the interstitium and intravascular. So you really want intravascular. So you're getting some intravascular. But really the most important thing that differentiates different types of fluid, you have crystalloids, which is normal saline LR, versus colloids, which is albumin blood products, is the fact that they're able to distribute to the intravascular space. And that's really what you want. You want a distribution in intravascular space so that you're able to target blood pressure, increase the blood pressure improve the blood pressure when someone has vasodilatory, shock. You want intravascular fluid space. When someone is, intravascularly depleted, that's usually when someone is, has low oncotic pressure, they have ascites, etc. That's when they call it third spacing. That means that they're like putting a lot of fluid outside of the intravascular. They're intravascularly empty, but their interstitium is kind of full. They might have edema, but they're intravascularly depleted. So that's why you could potentially give albumin. And that's why when you have patients with cirrhosis and you're getting fluid out, you have paracentesis, you give back fluid because essentially you removed a good amount of their intravascular space and also interstitium. You want to give back fluid to kind of help fill the intravascular space again. And so here's another idea, another approach of this. So this is kind of a breakdown of, do you guys want to take a picture? Go ahead. It is important. So what do you do when you have a patient who is coming in with sepsis? You want to deplete them. You want to give them fluid. Based on the data, there's a lot of trials, but there's some trials that show evidence that normal saline in a bunch of fluid actually could cause acute kidney injury. Their creatinine is going to be bump up, and that has to do with a hyperchloremic acidosis because of chloride. So normal saline isn't really normal after all. Normal saline isn't normal because it actually has acidotic. It becomes pH is low, versus LR pH is 6.5. And the price is really negligible. So it's not really a price thing. It's really just an educational thing. We just been always use normal saline. Just so you know, normal saline is harmful. It could be harmful for patients. Their sodium could go up. This is 154 milliequivalents per liter. So definitely if someone is coming in with sepsis, their poor PO intake, you give them normal saline, you're going to bump up their sodium pretty fast. So you got to always make sure that your sodium is not being bumped up too quickly. And, you could have demyelination of, brain cells, edema, brain cell edema, etc., from any acute changes of sodium. And so I always choose LR for septic patients, but I think the more important thing that you want to know is really what their sodium is. If someone's sodium is, for instance, 130 and you want to maybe bump it up, maybe you could do normal saline. It's going to go up. But a lot of patients who are hyponatremic, they could still have their sodium could still go above 130. It doesn't stop at 130, just so you know. But LR does have lactate, but the lactate actually it's confusing. It's not the lactate. It doesn't increase the patients don't become the lactate won't go up. If someone has a high lactate in the blood, it doesn't mean that you can't use LR. You certainly can still use LR. It has potassium, but it's very negligible. It's not going to increase their total, body potassium. So someone who's hyperkalemic, the potassium here is negligible. It's not going to increase their potassium. So that's really the kind of the majority of the discussion for the fluids. So now let's talk about antibiotics. If you guys have questions, we'll stop and we'll answer questions. Okay. Any questions, guys? I know I'm moving really quickly, but can we talk about rates? Yeah, I could talk about rates. So the way that I like to think about rates is like, maintenance, you have maintenance fluid, right? So usually you could use whatever their body weight is and kilogram. It's like a shortcut plus 40. So 70 kilogram man plus 40 is what? It's usually like 110, right? That's 110 cc's per hour, right? So that's usually the rate you're doing it. It's not a bolus. So there's different ways that you do it. That's kind of maintenance. Usually you do 100 cc's for most people for maintenance. Or let's say someone is MPO. So they're MPO and they're diabetic, right? You want to put them on an insulin sugar source because they're still getting insulin. So what you want to do is you want to put D5, right? D5W, which is D5 water. It's just pure water. That one I just kind of put 30 cc's per hour. So just like a maintenance dose of sugars so that they don't become hypoglycemic, basically. If someone is septic, based on the Rivers trial, which there's a debate on the utility of it, but just because you need to know this info. If someone with septic, you do 30 cc's per kilogram of bolus fluid. So meaning like, let's say 70 times 30, that comes down to like 2.1 liter, right? Of a fluid bolus. So you want to make sure you get 2.1 liters of either normal saline or LR. I prefer LR. So that's a bolus, and that's going to run basically it's going to be 999 cc's per hour. So basically 1 liter per hour, essentially. But they sometimes could run it faster, and they could give a bolus 1 liter every like 30 minutes or so. So they're getting it pretty fast though. Okay, so any other questions? Yeah, no worries. Okay, so let's talk about antibiotics, guys. I think that's an important topic. I won't go over every like detail of antibiotics. I think it's something that it could take a while to discuss, but I'm gonna just kind of give you guys a version of how I understand it. So I'm going to the next page on the whiteboard. So who feels comfortable with antibiotics so far here? Or who feels like they need more help with antibiotics? More help for sure. Yeah, I agree. It's not as intuitive as at least it wasn't for me. It's very confusing. So I'm just this is after today. I'm gonna give you guys a quick lecture on antibiotics, and I think this will be very useful for you, and you'll feel way more confident. I'm in surgery. I need to know other things except for ANSEP for everything. That's a good point. Honestly, you will know more than you'll know more. Trust me. After this, and you'll feel pretty proud of your antibiotic knowledge after this. Okay. So this is the end of this is different types of antibiotics. So we'll just cover. You have gram positive, right? And you have gram negative. You have anaerobes, right? You have, you have other, and you have other you have, so gram positive, gram negative anaerobes. And then within that, you have other bacteria that is important, right? So within gram positive, you have staph, right? You have staph, and staph comes in many different forms. You have MRSA, you have MSSA, right? So for those who don't remember, it's methicillin-resistant Staph aureus, methicillin-susceptible Staph aureus. So this is MRSA, meaning you have to treat it with something like Vanc, right? And then you also have strep, right? Strep, you have group A strep, strep pneumonia, and then you have Enterococcus, which is its own thing. Enterococcus. And then let's talk about gram negative. So gram negative, there's a bunch of other kind of ones that you need, like random ones that you don't have to really know, but the more important one is really Pseudomonas. You have E. coli, E. coli, we have respiratory like Klebsiella, Moraxella, etc. basically. So really the most important one is E. coli, Klebsiella, Moraxella, Pseudomonas, all these kind of things that are important. And then you have oral anaerobes, which is, you think of just oral, and you think of like GI. Anaerobic, you don't have to memorize which type of bug really. It's just kind of broadly speaking, you have to know which antibiotic covers anaerobic, which one has anaerobic coverage, which one doesn't. So the way that I approach things it's pretty intuitive. I hope you guys understand kind of the way that I approach. So just briefly, kind of you obviously amoxicillin. This is like something that you would use for MSSA, right? So definitely MSSA. It also helps with Enterococcus. But it doesn't. It's something that you obviously wouldn't use it for MRSA, and then it doesn't cover Pseudomonas either. And then moving forward to ceftriaxone. So ceftriaxone kind of does a little bit of both. It does cover MSSA. It does cover strep. It doesn't cover Enterococcus. That's something that a lot of people get confused on. It doesn't. So it doesn't cover Enterococcus. And then it doesn't cover Pseudomonas. So no Pseudomonal coverage. Okay. And then I'm just looking at my notes, just making sure I'm not forgetting anything specific. But yeah, it doesn't cover Pseudomonas. It does have some anaerobic, so there is some anaerobic coverage, oral. But that's typically not classically what we use for anaerobic coverage, especially for someone who's pretty septic. We use something on top of it to cover them for GI. Anaerobic. It doesn't cover. It's good for someone who's coming in with an aspiration pneumonia because it covers with anaerobes. But classically, you want to associate flagyl, which is metronidazole, for anaerobic coverage for both oral and GI. Okay, and then SOSIN. So it's like a ladder, right? So it's like a ladder. SOSIN is the next one. So SOSIN is basically piperacillin tazobactam, and that one is pretty good, right? So you have gram-positive coverage. It covers MSSA. It covers strep. It covers Enterococcus. it covers gram negative, like respiratory stuff, pretty much all of them. Enteric, it has good anaerobic coverage too. So yes. Pseudomonas definitely. So that's kind of classically what you want to associate Sosin with, pseudomonal coverage. And then it also covers anaerobes, both oral and GI, right? So it's great. So you notice that it's still missing, doesn't cover no MRSA. And obviously there's one no MRSA, right? Okay, then the next one is, what's the next one? Is Cefepime. So Cefepime is the next one. And Cefepime is pretty good too. You know, it covers staph, MSSA, covers strep. It covers, and it doesn't cover entero actually. And the reason why this is so these two, Cefepime are, they're both cephalosporins. So they don't cover enterococcus for that reason. They're very good for gram negative coverage. Respiratory wise, yes. It also is very, very good for pseudomonal coverage. So that's another option. You know, you have Sosin and Cefepime that are really good for Pseudomonas. And that's classically what you think of when you're in the ICU. The only consideration is when you have Cefepime, it doesn't have very good anaerobic coverage. It just covers oral, but you're still missing no GI. So this one is still for someone who's very septic, who's in the ICU and septic shock. Sosin covers everything. Cefepime covers everything that Sosin does, except it still needs some GI coverage. So you still want to use Cefepime with Flagyl, for instance, to make it as strong as Sosin is. Okay, and then you also have a bigger gun, which is meropenem, and these are carbapenems. These are a higher class. These are cephalosporins. Cephalosporin. This is a mix of tazobactam, piperacillin, which is a penicillin, and then a bactam antibiotic combined. Meropenem is a carbapenem. These are for what we call ESBL kind of. So these are for ESBL bacteria that are resistant to beta lactamases. So these are pretty strong antibiotics. So they cover everything, as you can imagine, from everything that we saw, except they don't cover so everything except no MRSA, right? So they're pretty good for everything. They cover the only thing they don't cover actually, no MRSA and no enterococcus. So no enterococcus. So really the big thing you have to understand is doesn't cover enterococcus. Sosin does cover enterococcus. Cefepime. So these ceftriaxone and Cefepime are pretty similar. The only difference is that this doesn't cover Pseudomonas. Cefepime does cover Pseudomonas. Sosin is better than Cefepime because it covers Pseudomonas, but it also gives you broader anaerobic coverage. Meropenem is stronger than Sosin because it covers beta lactamase resistance. So when someone has really high resistance, like you usually see this in patients who are like older, who have chronic Foleys, they have ESBL, UTIs, you want to put them on meropenem. And usually the way that I do this is you go back in their chart and you try to see if they had resistance in the past to ESBL, basically. And then in general, the things that I'm missing is, others. You have, aminoglycosides. So like azithromycin. So this is like good for like gram negative. So like atypical coverage of things. Atypical pneumonias, essentially. So usually you combine it for someone with a community-acquired pneumonia. You want to put them for ceftriaxone, and you want to put a aminoglycoside on top of it as well. And then, obviously you guys know Vanc. Vanc is, it's great. Vanc is basically role is for MRSA. Something that you also want to consider is someone who comes in with an AKI plus MRSA, you give them linaclid. Okay. Okay. So hope that helps. Was this helpful? And my camera died. Can you guys still hear me though? Okay, great. Let me charge my camera and I'll still be on. I'm going to be talking throughout this whole thing. But I'm glad it made sense to you guys. Let's just continue on. Give me 1 second. I don't need my camera. It's fine. Okay, so this was kind of the antibiotic discussion that I usually kind of think that it's useful. So I think the most important thing that I think I want to emphasize also is I want to give you guys kind of more value with antibiotics. So something you also want to consider is kind of this. Let's just talk about like how patients will present, right? So the biggest thing, especially in yours, I know that some people are in the ICU. So you want to know what a Pseudomonas, right? Pseudomonas. So what are the Pseudomonas? What are the things that you could use to cover Pseudomonas? You know, you have Cefepime, you have Sosin, you have meropenem, you have imipenem, you have ertapenem. Okay. Actually, you don't have ertapenem. It's dorapenem. Ertapenem doesn't cover Pseudomonas. This one you never use. You just have to know it. You'll look cool in rounds if you're like, oh yeah, imipenem covers it and dorapenem covers it, but ertapenem doesn't. A good way to like knowing which carbapenems cover Pseudomonas is mid, and then so meropenem, imipenem, dorapenem. So there's no E, which is also ertapenem. And then I like to know, I also like another way of knowing it is mid C for Cefepime, but it's not a carbapenem. Cefepime is a cephalosporin. So these are basically the more common ones you use, is Cefepime, Sosin. Meropenem is kind of when patients are really sick and they have ESBL. You want to use meropenem at that point. But when someone's coming to the ICU, really your first choice is Sosin. Really, Vanc Sosin is primarily what we use, but we want to if they don't need Vanc, you don't use Vanc basically. Okay, and then that's kind of the major gist of it. But let's just talk about different scenarios. Someone comes in with a pneumonia. There's a couple options. You know, they could be a community-acquired pneumonia, which is, you know, you just put them on ceftriaxone, acitro, or doxy, depending on your hospital. Is it you know, do they have a vent? Are they trach vent? Are the patients who have, are they trach vented and they're coming in because they have high purulence, they have infection? You want to think of a VAP. When someone has a VAP, you basically want to cover for MRSA and you want to cover for Pseudomonas. Really, primarily Pseudomonas is kind of the big one. And then, yeah, and then basically that's kind of the big ones. And then pneumonia, are they immunocompromised? So, and then they have a CT. Does it show like just really bad inflammation, ground glass, all these things? Then you also want to make sure that it's not fungal, right? Like rule out fungal infection. And then, you know, this is a little bit more than what you should know as an intern. I'm going to have different series of videos where I discuss like how to test for fungal infections, what we do as a pulmonologist. But that'll be in a later talk. I just wanted to give you guys that. Okay, so that's pneumonia. Urinary tract infection. Really, the big thing for urinary tract infection is, are they having symptoms? First of all, you don't treat a patient if they don't have symptoms. So dysuria, increased, frequency, incontinence. So those are all symptoms. And patients with prostatitis, are they like having pain, and you do a prostate exam and it's very tender, then you want to give them antibiotics. But if they don't have symptoms, they don't need antibiotics. And UTI, that's more of an outpatient thing, but ceftriaxone is more than enough for most people. And inpatient, when they're septic with a UTI, ceftriaxone is more than enough. That's all you need. But you also want to consider, do they have chronic Foley? Are they like, do they have chronic Foley? Look history of resistance. Really, that's a big thing. And if they do, you want to consider carbapenem. So that's like, that's what we talked about. That's meropenem. That's, ertapenem, basically. But usually it's meropenem. It's kind of what we start with. And then, other thing is, skin infection. Okay, is it cellulitis? Is it just like vascular? So that's the thing. It's that there's no such thing as bilateral cellulitis. If there's redness and it's tender, it's probably some vascular problem. If it's bilateral, cellulitis is usually like unilateral kind of erythema. So then you could just kind of put them on. You just want to put them on a gram-negative, gram-positive coverage. Unison is more than enough. Unison is a good antibiotic for both gram-negative, gram-positive. If you're thinking that they could have MRSA because there's purulence, or there's like IV drug use, then you could do VANC, obviously. The other question is it bone? Is it a bone infection? And the way, it's kind of hard to know, but the most sensitive test that you want to use is an MRI. But there's also something called a bone, like a probe bone. So you grab are you able to touch the bone with there's a cotton swab, I guess, or like those sticks. It's called a prone bone test. And the MRI, you can get an MRI if you feel like it's suspicious for osteomyelitis. If they're not septic, you hold antibiotics. Hold antibiotics if not septic. The reason for that is you want to get cultures, bone biopsy, because if you give antibiotics, now you don't know what you're treating. But if they're septic, you give antibiotics. Okay. You give broad spectrum, right? And that's going to be, you could do VANC at that point, and then ceftriaxone if you wanted to, or you just go straight to vancomycin, depending how sick they are, if they're like hypotensive too. So that's kind of the approach that I take. I hope that was useful to you guys. I could continue talking about this, or I could move on to the next topic, which will be ICU stuff. What do you guys think? You guys take a picture of this if you guys want, or you're good at antibiotics? Okay, cool. Was this something you guys already knew? Was this something more information you guys got? Did you guys gain more information from this couple minutes that I spent on antibiotics? Great refresher. Okay, thank you. Yeah, I'm glad it was useful. This was helpful. Awesome. Yeah, I'm really glad it was helpful for you guys. Okay, so we talked about so let's talk about a couple of things, guys. First of all, thank you guys for still being on here. I know it's been a long day for you guys. I want to talk to you guys about, let's talk about vents, or let's talk about ICU stuff. There's a lot of things that I could spend talking about ICU, so I won't spend too much time. I'll make it kind of brief. So these are the kind of topics that I'll expand on in other videos. Being in the ICU, you need to learn how to interpret an ABG, know the basics of vent, know shock. And that kind of goes hand in hand, right? Because you need to know how to interpret an ABG to be able to titrate or understand what the vent, how to change the vent. Shock, like causes, and then vasopressors. Really, that's kind of most of it, honestly. As an intern, that's really all you need to know. And if you know these pretty well, you'll be good. You'll be solid. Okay. So I'm gonna make it super easy for you guys. So ABG, right? An ABG versus a venous blood gas. Okay. The pH is equal to the pH here. I'm gonna say for the most part. Okay, that's not always 100% true. Okay, but for most purposes, it's true. There's some slight difference, but more accurate is always the ABG when it comes to pH. PCO2, pretty accurate, when it comes to both. The difference is the PaO2. PaO2 is that's really you want to get an ABG for a PaO2. This one is the venous AO2, venous gas is not at all related. You already have the muscles already kind of took up the oxygen, so it doesn't really give you a good reading of the oxygen in the blood, basically. So that's essentially what you want to do. So for the most part, if you want to really look at how well someone is in terms of respiratory function, the PaO2 is important. But then you might be asking me, but why are we going off the PaO2 when we could just look at the SpO2? That's a really good question. And the answer is we don't need to get an ABG to tell us how well they're oxygenating, right? The SpO2 is, for most of the time, is good enough. Okay, good enough. The only reason why you want to get an ABG is to be able to really understand the severity of things. What is our PF ratio? Meaning, what is the ratio between the PaO2 and the FiO2 I'm giving these patients? So these patients are ventilated, right? They're ventilating, and we set, depending on the mode, or actually all modes, we set FiO2. All modes we set FiO2. It doesn't matter what mode. You set how much oxygen, concentration of oxygen they're breathing. And so that is going to allow us to understand the severity of things. Because if you could imagine, if someone is getting 100% FiO2 versus 50% FiO2, they might still have the same SpO2, right? They might still be like at 95%. If you look at this, you'll be like, oh, wow, they're both doing really well. But actually, no, this person's doing really bad because he's 95%, but he's requiring 100% FiO2. Room air is 21% FiO2. So 100% FiO2 is way more. It's a lot, right? So the PF ratio, you have less than 300 is really when you start thinking that's low. And then you go less than 100, less than 200. So that's moderate, mild. Less than 100 is severe. Okay. So that's kind of the idea that I'm trying to get behind. But you typically don't need to get an ABG all the time. It's important to get an ABG once in a while to kind of understand the PF ratio, and it's going to help us, especially with ARDS, with management. Like, should we paralyze them? Should we not? Should we prone them? Should we not? That's going to dictate based on the PF ratio. You prone patients if the PF ratio is less than 150. You consider paralyzing them when there's below 100. Okay, you consider paralyze prone, you consider ECMO, extracorporeal membrane oxygenation, when it's less than 50. So really the most important thing is helps you understand severity and potentially might change management. So let's talk about Vance. Let's finish up talking about ABGs. So the way you interpret an ABG is important. The way you read an ABG is important. So like I mentioned, really you're going to get a pH space CO2, and then you'll get the venous O2 here, right? And this part, you're not going to read that out. It doesn't matter. So really, for an VBG, all you're reading is a pH and CO2. That's really what matters. For ABG, you're reading the pH, the CO2, pH, CO2, and you're also reading the PaO2, right? And then it gives you bicarb 2 here, but that's like a calculation. Really, the bicarb should come from the Chem 7, from your lab. So let's interpret ABG. So a normal pH is 7.35 to 7.45. A normal PCO2 is 35 to 45. Okay, and then PaO2 is typically greater than 60. That's what you that's what you want it. But really, in order to know what severity, it comes out to the PF ratio, right? Like I mentioned, you want it to be greater than 300 to be normal. Typically, the way that I like to think about it is your PaO2 should be 5 times your FiO2. So take this, 24 times 5 is what? So it's like that's greater than 60 for sure, right? So greater than 60. So the same idea applies. 21, I mean. So 21. So it's like 100 something, right? So that's kind of a good way of understanding how severe it is. But another way of doing it is just looking at the PF ratio. So then when you get an ABG, and then also the pH, and then bicarb, normal is like 22 to 28. I'm not going to go over like the Winter's formula, all these compensation rules. I think that's something you could do as you go with training, and I'll just keep it simple for today. And I'll definitely go over it later if you guys want me to. But basically, you have a pH, right? I'll give you an example. You get 7.22, 70, right? And then let's say it's 65, and then you look at the Chem 7, and then that's CBC, whatever, doesn't matter. This is a Chem 7. Their bicarb here is, let's go with 31, right? So then you could say here, okay, they have, so we know that this is low, right? Okay, because it's below 7.35. We know this is high because it's above 45, okay? This is PaO2, okay, it's 65. Doesn't tell me anything. I haven't told you how much oxygen they're on. So I look at how much oxygen they're on and I calculate a PF ratio. But when you're saying it out loud, you just read it out. You say ABG is 7.22, 70, and 65 with a bicarb of 31 on the Chem 7, basically. So then if they want you to interpret it, you're going to say, okay, so this is high too, right? So if the CO2 is high and that is causing the CO2 is causing the pH to go low, right? Versus if the bicarb was high, it would actually be causing, if there was a primary metabolic problem, it would actually be causing the pH to be going high, to be elevated. But that's not happening here. Actually, the CO2 is driving the acidosis. So you say, and the CO2 is all respiratory because you breathe in and out, right? So you say it's respiratory, acidosis, and then you could do, Winter's formula to calculate it if it's compensation. But I think in this case, there's a compensation with metabolic compensation. But calculate it and you'll be able to tell. That's kind of the idea. And there's calculation. There's a MedCal calculator that I use a lot of times, just when I don't want to do simple math. And it tells me exactly based on which formula I need to use, if there's compensation or not. So that's kind of the idea here. And so now let's take this data and see, how do you interpret, how do you change, how do you make vent changes? Okay, so then I tell you, okay, this patient is, there's different vent modes that we use in the hospital. Primarily the one you're more familiar with is, so I'll just break it down really quickly. Vent modes, I'll give you it's like a 2-minute lecture on it. So there's pressure control, and there's volume control. With here, we set pressure. Here we set volume. So typically, we have the more common one you use for the volume control is called assist control, volume control, or there's some machines call it synchronized, mandatory. So it's C and V, synchronized mandatory ventilation. That is basically gonna give you you're gonna basically set the rate. You're gonna set the PEEP. You're gonna set the tidal volume, and you're gonna set the FiO2. So this setting really comes, you don't know, the patient has pressure here, right? This is pressure. This is kind of obviously we could just say time. So during inspiration, they're gonna have a set pressure, and then they're gonna come down, kind of thing. So you can't control the pressure that the lung is getting, because you are putting a target tidal volume. So the lung is going to try to reach whatever tidal volume you want it. And then there's also there's also here, you're going to have, based on that, you're going to have, once it's here, it has, the tidal volume, that it reach a tidal volume kind of thing. So you're setting the tidal volume. So it's going to, during inspiration, it's going to try to reach that tidal volume. And then you won't be able to control whatever pressure the lung is experiencing, because you're targeting that specific tidal volume. And that pressure really comes down to the patient's lung compliance. So the lung compliance is really, in that pressure, it's called peak pressure here. And then you could do a hold, an inspiratory hold. This whole thing right here is during this whole thing is inspiratory phase. This whole thing is expiratory phase. Here's expiratory phase. You could put an inspiratory hold here when you're basically letting the machine be like, hey, make sure you hold the breath and measure how the pressure is inside that during that breath. And that's called a plateau pressure. When both the extrathoracic and intrathoracic pressures are equalized, that's plateau pressure. And that's going to give you a good measure of compliance. How good is the compliance? Okay, so then, but you can't control the peak pressure. That peak pressure is based on the patient's overall kind of compliance. You can't change the plateau pressure either as well. So if usually the plateau pressure is high, the peak pressure is also going to be high. But there's some indications in which the ratio of the peak pressure is way more higher than the plateau pressure, and that could tell you that there's something else going on outside of the lung. And that's a discussion for another day. But basically, this is kind of the Cliff Note version of it. So, sorry. So let's see. So the way that you start with the rates is, usually when you have someone coming in, tidal volume, it really comes down to their body weight. What's their ideal body weight, and that will give you an idea of their tidal volume. And there's different ways that you guys could look at it, but usually start with tidal volume. You do 6 to 8 cc's of kilogram of on ideal body weight. So 6 to 8 cc's per kilogram on ideal body weight, right? That is kind of, usually you start with 6, but 8 is probably fine too. And then the goal is to continue going down on tidal volume. So low tidal volume is kind of useful for lung protection. And usually that is something that we know in ARDS patients. And then the rate that you want to use is, usually, 15 cc, 15 rates per minute, breaths per minute, I should say. Okay, and then FiO2, when you're intubating someone, you start at 100%, and then you titrate down as they get better. And then PEEP, you usually start at 5, and then they might need more. You go up on it. Okay, so let's go over. So the next slide, or next whiteboard paper. So like I mentioned, you have the volume control. So the important thing that you want to also know is that you're setting a rate, let's say at 15, but the patient could breathe over the rate. So the patient could breathe, let's say they're tachypneic, and they're breathing at their natural breathing rate is 15, they're able to breathe over that. When they get with supported breaths, they get supported breaths at whatever PEEP you gave them. Okay. So that's the good thing about volume control, is that if patients they're getting a lot of fentanyl, fentanyl decreases their respiratory drive. And so they need to be on a volume control, because if they stop breathing, they have a backup rate. So what do you do about the ABG? Let's go back to the ABG. Now that you guys know, okay, cool, I understand. So you have the rate, you have the PEEP, tidal volume, and FiO2, right? Okay. So the way that I would arrange it, is asking yourself, what affects PaO2? What affects PCO2? PaO2 is affected by PEEP, and it's affected by FiO2. And PCO2 is affected by rate and affected by tidal volume. So what does that mean? The rate times the tidal volume is called minute ventilation. So how fast am I breathing? You could have someone who has a really fast breath, but really small tidal volume. They're really shallow breaths, right? They're breathing really, really fast, but they're not really taking much breaths, versus someone could have really fast. They could be really fast, but they're breathing deeper in, right? So that's the minute ventilation, essentially. And then you have PEEP, and you have FiO2. PEEP is going to open up their, prevents atelectasis. FiO2, increases the amount of oxygen for the alveoli to dissociate. So if someone has a high PCO2, what's the first thing you want to do is you want to, obviously you want to change the rate first. Let's change the rate. Let's go down on the rate. And then you could change the tidal volume if you wanted to. That's kind of the priority that I would use. Someone's PaO2 is low. First thing is FiO2. Go up on the FiO2. And then if that is maxed out, you can go up on the PEEP. Because PEEP could also increase the peak pressure, and their lungs are really stiff. It could cause pneumothorax. So that's kind of volume control. Pressure control, on the other hand, is basically you're setting the inspiratory pressure. You're setting the inspiratory. You're also setting a PEEP. You're also setting a rate, and you're setting an FiO2. Question mark is tidal volume. You don't know what the tidal volume is. You're not able to control tidal volume. This mode is useful when patients have high peak pressures. My experience is we usually start with volume control, and if the peak pressure is really high, we switch them to peak pressure control. But usually you start with volume control, just because we want to really target tidal volume, because with patients with ARDS, it's all about lung protection. And that's low tidal volume, high PEEP for the most part, right? There's other reasons why that could not be true, or that doesn't have to be true, but for your understanding, low tidal volume, high PEEP. But yeah, this one you don't know. You can't control the tidal volume. It really depends on their compliance again. How well they're able to, you might have to go up on the pressure to reach a specific tidal volume. So hope that was helpful. That's really the majority of things I think as an intern you need to understand in terms of vents. There's a couple nuances, like, who gets to be extubated, what are the indications to be extubated, what's a weaning trial, all these things. And I think that's something that I think you will learn as you go. So there's a couple of things I think now that I know that we needed to discuss. I kind of covered a lot of ground already, but we talked about ICU vents, ABGs. Let's just finish up ICU with shock. I'm going to give you guys a pretty quick understanding of it to help you guys. Next is the next whiteboard. So shock. So you have cardiogenic. You have distributive. You have cardiogenic, distributed, obstructive. You have also, hemorrhagic, right? Yeah. You could have anaphylactic. So you could think of hemorrhagic almost as a type of distributed. So they're kind of a little bit connected. So talking about cardiogenic, it's like an MI, heart failure, right? Essentially, distributive is septic shock, hypovolemia, you could also have a medication induced, like in the OR, patients definitely go into distributed shock from medications while they're getting it before intubation. Obstructive is, you could have a tension, pneumothorax. You could have a massive PE. This is important, massive. Not every PE is obstructive. A massive is a PE that causes shock. So really anything that you have, RV failure, and you could argue that RV failure potentially could go into cardiogenic shock. And this is like, trauma, right? GI bleed. And then anaphylactic is, either food or drug, drug induced. Okay. So let's talk about kind of pressors now. Well, actually, let's talk about it, really what each of them means, I guess, because that's going to help you understand what pressors are. So really, that's a low cardiac output, right? You have a low cardiac output state. You have high systemic vascular resistance. Okay. You have high preload because everything's backing up. This one, you're having a high cardiac output, low systemic vascular resistance, low preload. That's really the most important ones. For obstructive shock, you do have a low cardiac output. Systemic vascular resistance is unchanged for the most part, and preload could be high. Okay. Hemorrhagic, low systemic vascular resistance, low preload. And then cardiac output could be high too. Anaphylactic is cardiac output might be the same. Systemic vascular resistance is low because you're vasodilating essentially. Okay, so let's talk about kind of the different pressures that we can use. So there's classically a way to kind of understand it that I think is important. Sorry, pretend that's a straight line. Okay, I'll just do it again. Okay, so this is the way that you should understand it. So you have positive inotropy, vasoconstriction, vasodilation. So you can think of vasoconstriction as increased systemic vascular resistance. That's like afterload, basically. This is decreased systemic vascular resistance. Okay. So let's start here. So when you guys think of what is a positive inotropic agent, you want to think of the butamine, right? You want to think of the butamine as being something that's really strong, gives you positive inotropy. You could also think of epinephrine. So epinephrine gives you positive inotropy, but also gives you some vasoconstriction as well. But you also get, this is low dose, high dose epinephrine. But really the more common vasopressors that we use in the ICU are levofed or no epinephrine, no epi. So no epi really gives you a little bit of both. It gives you really good vasoconstriction. Doesn't give you too much inotropy. It gives you a little bit of inotropy, but really the most important thing is for vasoconstriction. So that's what we use it for septic shock, because septic shock you have vasodilation. And then you also, I should have used different colors. And then here you have phenylephrine or neo. It's called neo for short. That one's also good. So it's a pure vasoconstrictor. So all it does is vasoconstrict. So it's great for people who it's like a third line you could use for someone who's very has a very bad distributed shock. But the first line really for someone with septic shock, or really kind of most shocks, is you do levofed or no epi. Second line is vaso. And the third line is, you could use phenylephrine or neo. There's different ways, you could go around it. But if someone has, for instance, like cardiogenic shock, then you want to use the butamine as first line. If you're not really sure exactly what it is yet, levofed is a good one just to start with. And then you also have like nitro peroxide here. It's a good vasodilation. And you have midodrine here as well. But that's not something that we comment. It's more of a PO medication you could take. So that's really the big ones you want to focus on is this one, phenylephrine, dobutamine, knowing that it causes anatropy, epinephrine causes vasoconstriction. If you know this, really you're set. Vaso, and then I forgot to tell you, vaso's here. Vasopressin. It's called vasopressin. And this one is set. Usually it's like you can't titrate it. So this is the only vasopressin is really the only pressor that is fixed. It's a fixed dose pressor. You don't titrate it. So I hope that was helpful when it comes to the pressors. So I think I'm going to finish the talk with a couple of things. If you guys give me a second, I want to just thank you guys for joining. I know there's some people who have been coming on every weekend listening to me talk. I really appreciate you guys. This is unfortunately the last live session that I'll be doing. And I'll tell you guys what I'll be doing next and see if you guys are interested. But before I do that, I I want to kind of give you guys last couple points about how to be efficient and how to, how to learn on the job, how to respond to pages, how to multitask, and, how to take breaks. So the way that I want to focus on like multitasking is a lot of people, we talked about it on the first live session, but make sure that when you're rounding and the attending is going over something, make sure you have a checkbox. So let's say call cardiology, and then remind yourself why. Be like, okay, heart rate, tachycardia, or medication or something. I don't know. Write something down so that you remind yourself. This doesn't make sense because clearly it's not like a sentence that explains everything, but almost like a reminder to you of like what you need to do, and have a priority. So be like, okay, order labs, or you write down exactly what you need to order. Don't just say labs, actually write down what you need to order. Priority should be anything that could affect patient care. So if they ask you to, put antibiotics, priority is patient care. So if you need to see someone, need to see patient, then do it. Don't wait. Okay, and then 2 is putting orders that will affect patient care. Orders. 3 is calling consults because that will affect patient care. 4 is communicating to others like staff, to nurses, pharmacists, etc. And then 5 is like other things. Lastly, and then at the very end is notes. So I know we have a tendency to like want to write notes from the beginning, and obviously depending on how strict your attending is, notes comes last. And notes is just a way for you to be able to have a list of what you did, but you want to make sure you get everything done before you write in the notes. The way that a lot of people like to do it is they come in the morning and they have like a template. So make sure you have a template of notes, like smart phrase. So come in the morning. So start note in the beginning. And then start note, basically it's like a SOAP note, right? Subjective, objective, and it kind of auto populates like this part. The assessment plan is really where you start thinking that you could write it throughout rounds or before rounds. But you don't have to finish your note until after rounds. You don't have to have your notes done until after rounds, until you guys talked about the plan. You could always pen your note. Okay. So now a little word about consults. So when you call consults, right? It's really important to understand like why you're calling them. What's your question? You're calling a specialist, right? So it could be a pulmonologist, like in my case, it could be a cardiologist, etc. You really want to make sure that you actually understand why you're calling them, and start with that. Be like, hey, I'm calling you from the medicine team. I had a question about a patient with X, and we were wondering about why. Okay, so now you painted a picture. You're okay, cool. Now I can listen to you, instead of saying, hey, this is patient whatever, 55-year-old guy with blah 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 blah, and the person's probably like listening to you, doesn't want to be rude, but the whole time is trying to understand like why you're calling them. So like probably didn't really listen to anything you said. I'll be honest with you. So what you want to do is be direct. I need this. So I want you to answer this question for me. Does this patient need this procedure? Does this patient need this lab? How do I manage this specifically? And then pointed questions related to their system, right? Like if it's a cardiologist, make sure you have an echo. Make sure you have an echo, EKG, tropes, BMP, volume status. Make sure you have all that info. chest x-ray, etc., right? You want to look, make sure you understand. If it's a pulmonologist, do they have a CT? Do they have PFTs? How's their lung sounds? That's not that important really, but in general, it'll be helpful. What's their volume status? How much oxygen they're on? Is that an improvement in, better or worse? I'm guessing it's worse because you're calling a specialist, etc. If it's GI, are they actually having active melena? Did you see it? What's their CBC, hemoglobin, platelets, etc.? What's their history? Do they have colonoscopies? Are they getting any LFTs? All these things, So just kind of understand really why you're calling them, and then the data is important too. Make sure you have the data and the story. Responding to pages is something that's really important. You're going to be getting a lot of pages as an intern, and it might be really hard to juggle everything. So I think the most important thing that you want to understand is calling back people and telling them if you're busy, just let them know, hey, I'll give you a call back. You don't want to ignore a page because you get in trouble. Unfortunately, you might get called out and it might not look good, especially when you're halfway through the year and you should know better. So just try to respond to pages at a timely manner. And if you can't answer them right away, just tell them you'll call them back and remind yourself to call them back. So I know that this has been going on for a while, this lecture. So I wanted to kind of finish. Before I finish, I want to see if you guys had any questions. And I was going to share something with you guys before you guys leave. Let me know if you guys have questions. Okay, so I think some of you guys have been, I know that a lot of you guys have seen kind of the free videos. If you guys haven't seen the other sessions that I've had, I really would want you guys to try to take advantage of those, because I think I go over a couple more things there too. Things like how to present better, how to improve your presentations. But I hope that I walk you guys through kind of a little bit of everything, what is required when it comes to being a resident. I know that it could be very challenging being an intern. But I think at this point, you have to understand that it's a learning process. You have to understand that no one's going to fault you for not knowing things, and it's okay not to know things. I think the most important thing, if you got anything out of it, is to not lie, to be professional, to be nice, to be humble, to show everybody respect. I think that's the most important thing. And I hope that that's going to be something that could help you guys on your way, to becoming a really great doctor. Sorry guys, give me 1 second. I was going to show you guys something that I'm creating. Okay, so let me just show you this. I'm going to share my screen. So I'm going to close the whiteboard and I'm going to share my screen in a little bit, if I know how to do that. I don't know why it doesn't allow me to share my screen. So you think that Zoom is pretty intuitive, but then it's not. Okay, so I'm going to share my screen, guys. So there's something that I'm creating. I gave you guys a lot of free content, and I'm really happy that you guys are using that. There's it takes a lot of time for me to make these videos. I wish I could dedicate more time making the free content, but it takes away time from being with my newborn, from other things that I have to do. So I'm creating a Patreon page, or I created a Patreon page that if you guys, sorry for the picture, if you guys wanted to support me in any way, the way that I walk you through kind of what I'm doing. So there's a couple benefits. There's a couple tier systems that I'm doing here. If I could find it, give me 1 second. So I don't know why it doesn't show. Sorry, give me 1 second, guys. So there's a couple systems here. I'm going to be providing pretty much weekly content in this kind of way that I'll be doing it is I'll have at least weekly videos. They'll be way more in depth than the videos that I've made today. They'll be discussing more patient presentations. I'll be going over cases, obviously HIPAA compliant, not sharing any HIPAA information, but I wanted to make mock cases in which it could help you a bit better. And I'll be making videos every week. I'll also be having, if you enroll in this, it's like, I'm going to lower the price for you guys. For this week, it's going to be like 20. But let me know if you guys want to sign up. But essentially the plan is to make sure that I'm able to kind of make content for you guys, make monthly group Q&A sessions in which you guys could ask me questions and I could further have more discussions on specific topics that I covered. I'm also going to have like a Discord group for everybody who's members. And I'm also going to have exclusive like summaries of each video. And each video is going to be topic specific. So like I'm going to talk about, let's see, tachycardia, rapid response, rapids, if you get a rapid, code blues, kind of how to run them, pleural effusions, all these different topics. And I'm also going to be having kind of questions that could help you for the boards as well. So this is something that I really want to dedicate myself for the next years. So this is exclusive content that I'll continue making, content for. And I want you guys to take advantage of that as well. And I'll be making note summaries of each video, and each video should not be more than 5 minutes. It'll be very quick or even less, kind of nugget information that's relevant. And I think this could really substitute your studying. I know that as an intern, I used to struggle finding time to study. There was just so much information out there, and it was hard for me to really consolidate what was important, what wasn't. My hopes is to really put that all together so that I could just tell you this is exactly what you need to know in a very direct way so that you spend less time studying and more time really enjoying medicine. This other package is really, I understand it's super pricey for a lot of people, but the goal isn't really for a lot of people to do it. If it's one or two people that want to do it, this is really more for those who need extra help. Like more individualized help. They want to talk to me personally, one-on-one meetings, check-ins with me, more of as a mentorship type partnership. Then this is something that I think you'll find some advantage in. If you want to go into fellowship, I'll give you guys some information, individual information for that. I'll go over case questions for each weekly video. So it's more of like a Q bank that I'll give you, individualized topic requests. So if you guys have specific struggling with certain areas, you could request specific topics and I'll be able to cover them individual videos for you. You'll also have access to individual Discord separate from the super intern Discord. It'll be more of individual for you. And then you also have a mindset coaching session with me monthly to really just kind of gauge how you're doing in residency, how your wellness is doing. I think the goal right now is the way that I'm pricing it is I want to just make sure that I get a lot of people to join, and then eventually the pricing and more benefits will continue. I really hope that you understand that this is something that I really do want to provide as much content as I can. I'm going to be getting a better speaker, better camera to provide you guys with better quality. The goal is also eventually to make sure I hire an artist. So when I'm narrating these kind of videos, I have an artist drawing out everything that I'm saying and better, obviously better writing and having drawings, the cartoon drawings and stuff. So if you guys are interested, let me know. You can message me individually and I'll send you. So quick question. So only super seniors can request topics for video? Yeah, that's right. Thank you, Terrell, for linking that. So only super seniors can request topics for videos. I think right now, that is the plan, just because I have a set curriculum that I'm like trying to do. Of course, like you guys can message me too, and I'll be able to make any video requests, honestly. but they just have privilege when it comes to their own requests. So if there's a lot of people that sign up for the super senior package and I'm getting like a bunch of requests, I'll make those videos first. But if you're a member, I'll listen to you and I'll do whatever you need help with. I'm here for you guys in the end of the day. It's not really about, for me, it's not really about money. It's really more about trying to find time for these videos. So that's the reason why I'm valuing it like this, so that I'm able to provide more money for myself to make better videos in the future. So if you guys are interested, let me know. I'll be making, there'll be 2 videos that I'll be making tonight, and I'll be posting them tomorrow in the evening. So if you're interested, let me know. I'll send you the link, or actually Terrell actually sent the link already. So thank you, Terrell. I'm also going to be sharing this Patreon page to a lot of people that message me. I've gotten, I don't even know how many messages. I've gotten over close to 1,000 messages already about the boot camp. And so I've been responding to everybody individually. And so I'm going to send them a link and see if they're interested in joining. Again, no pressure. In the end of the day, I understand that money could be tight for some of you guys, and you still want to, take advantage of education that you have. Message me if money's an issue. Let me know what I'll figure out something I can do for you as well. Okay. I want to make sure that you guys, in the end of the day, if you have the money to support me, great. If you don't, then that's okay too. I'll do whatever I can to make sure that I provide at least some content for you or some guidance. So that's essentially kind of what I was going to say today, guys. I know I don't want to promote myself too much. I already did enough of that, but I just hope you guys enjoyed the free content that I have. I have this will be the 4th video that I recorded. I'll post this online on YouTube as well, so you guys could go back and look at it and learn from it again, and reference it whenever you're struggling with a specific topic, for instance. But this is a very cookie cutter kind of basics introduction to the premium content that I'll be putting out. The goal of the premium content is to really expand on everything I talked about and even introduce you to more topics. So I think you'll really get a lot of value from those topics that I'll be covering. Does anybody have any further? And thank you for the question, Chrisleen. That was a really good question. Great question. Okay. I'm sorry that my camera, I'm using my DSLR camera, so the battery died. So Terrell ended up linking the Patreon, so I really appreciate you, Terrell. Thank you, everybody who's been here, been really great listeners, great questions overall. Feel free to message me. I'm always on Reddit. I'm always active on Reddit. If you have any questions about what I discussed or really anything at all, I'm really here for you guys. I want you guys to succeed and just crush intern year, be the best kind of doctors you want to become. And I know it's going to be hard. I know you guys are nervous or still scared. Even if you listen to my course, I'm still sure you guys have some anxiety. That's normal. That's okay. Embrace that anxiety, because that anxiety is going to allow you to become more aware of, what you're doing when you're putting in orders. It's going to double check, triple check. I want you to do that. I want you to be careful, because in the end of the day, we are affecting lives in different ways. So I want to just be a guide for you guys. I want to be there for you guys when you see your first patient who, passed. I want to be also there when you're graduating. So I'm in it for the long ride for you guys. This is something that I'm really passionate in, and I hope that you guys could see that. So again, thank you everybody who was here and really listened to me. And I thank you for, spending almost an hour and a half or almost close to 2 hours now of your time. Any other questions? If not, I think I'm gonna finish the stream. Thank you, Tara. I really appreciate you, man. Okay, well, thank you guys for all the support. I really appreciate you guys. I'll see you guys. Hopefully, I'll see you guys on the Patreon page. If not, you know where to find me on Discord and on YouTube. Thank you guys.